Once again, thank you everyone for joining us today. It's a beautiful sunny day outside, and I appreciate you being here on your lunch hour. I think it's really important to be here. Today is the fourth of five sessions in our series on the future of primary care in BC. And today we're looking at the role of nurses and nurse practitioners improving primary care in the province. I'm Veronique Siufi. I'm the racial equity researcher and policy analyst with BC Policy Solutions, and we work on the unceded stolen territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. And for those of you who may not be familiar with our work or joining us for the first time in this series, BC Policy Solutions is a progressive policy research institute. So we're looking for those redesigns that are going to make life in this province better, as in healthier, more sustainable, more affordable, more just. So we've got economists calculating how we can better redistribute wealth and how investments in public and social infrastructure are not only the right thing to do, but good for the economy. We've got social scientists like myself doing community-driven research. We're also a hub for cross-collaboration across community organizations, nonprofits, academics, and the labor movement. And we also try and make all that work that we do accessible to all of you, which is what you're tuning in for today. So for those of you that have been tuning in all along, you've seen that this series has focused on, I think, a particularly great example of how when we design public systems with equity in mind, meaning when we make sure our systems work for the most marginalized, they end up working really great for everyone. We're seeing that this requires, clear values-based guidelines, some community responsiveness, some stable funding, of course, and that we stop treating our public services like market businesses. Now, we're incredibly fortunate today to have Lindsay Hedden as our guest facilitator. Lindsay is an associate professor in the Faculty of Health Sciences at Simon Fraser University, a Michael Smith Foundation for Health Research Scholar, and a principal investigator for the Health Systems Research Lab. Lindsay has an extensive background in applied health services research with a strong focus on finding solutions to the primary care access crisis, which is what we've been dealing with in this series, particularly for communities experiencing marginalization. Her research has investigated and investigates why the availability of community-based primary care has declined and explores how interdisciplinary team-based models can be used to improve practice and planning. So you can see why we invited her. She grounds this work in direct partnerships with health authorities, frontline professionals, and patients, and she's worked directly with the BC Ministry of Health on the development and evaluation of new models for primary care delivery, among other things. So obviously, Dr. Hedden's expertise makes her the perfect person to guide this session of our ongoing primary care webinar series. So I'll pass it to you, Lindsay. Thank you so much for being here today.
Thank you so much, Veronique, for that lovely introduction. So I'd like to begin just by acknowledging that we are gathering today on Indigenous lands. While this event is obviously virtual, our participants are joining us from communities across the province, a province of remarkable Indigenous diversity, home to nearly 200 distinct First Nations and many of Canada's recognized Métis communities. We acknowledge that the lands from which we each connect today are unceded and ancestral territories of many First Peoples of BC whose stewardship of these lands and waters continues to this day. And as we begin, I'd invite you each to take a brief moment to reflect on our shared responsibility to honor these relationships and consider how we can each contribute to meaningful reconciliation. So as Veronique mentioned, this is the fourth in a series of 5 webinars that are collectively exploring a better direction for primary care in BC, with a focus on not-for-profit team-based models of care that are directly responsive to local community needs. The first 3 webinars focused on why primary care works better when it's team-based, community-governed, and not-for-profit. What we can learn from Ontario's approach to not-for-profit primary care through their community health center model. And then the last webinar focused around how we can respond to the mental health crisis through primary care. And there's a link in the chat that will take you to those past webinars. So if you're not able to join us for those, you can, of course, watch the videos. Today, we're going to focus specifically on nurses and their expanding and growing contributions to team-based primary care across BC. And just to sort of level set, when we are talking about nurses, we mean RNs or registered nurses, LPNs, licensed practical nurses, and NPs or nurse practitioners. And we might touch a little bit on RPNs or registered psychiatric nurses as well. There's a growing body of international and Canadian scientific evidence that speaks to the ways in which nurses are working in primary care and how their work in primary care results in increased patient access, improved management of chronic health challenges, and increased attention to preventative care and patient education. We also have some fabulous success stories from here in BC, and we're going to hear about some of those from our panelists today. Beginning back in 2018, we've started to experience a real shift from physician-only to interprofessional team-based care in this province, including some quite significant increases in the number of nurse practitioners working in primary care as autonomous advanced practice nurses. And these NPs provide comprehensive primary care to individuals and families across their lifespans, and they do this alongside their physician colleagues. And then starting in 2020, the ministry also funded 4 nurse practitioner-led clinics, and these were modeled on Ontario's NP-led clinics. They're also team-based and run as not-for-profit organizations. Until recently, the ministry also provided funding to our provincial primary care networks to recruit licensed practical nurses and registered nurses who would be employed by the regional health authorities, as well as additional allied health professionals like social workers, clinical counselors, and pharmacists. And the intention behind this funding was to support this shift from physician-only to team-based, interprofessional team-based models of care through patient medical homes. Unfortunately, and I think we'll hear a little bit more about this from our panelists today, that funding has now been exhausted. And the only funding that remains for adding additional team members other than physicians and NPs is a small nurse in practice program that's been made available to family practices that did not receive funding through the primary care networks. And this small amount of money specifically supports RNs and LPNs who are working directly within the context of physician-run practices, with the goal of increasing timely access, improving follow-up, care coordination, and health outcomes for patients. Before I introduce our panelists for the day, I did want to mention the fact that we collectively recognize that there are many other professional groups that are providing essential services in the context of team-based primary care. So peer support workers, community health workers, First Nations elders, multicultural brokers, and many others. And because there are only 5 sessions in this series, we haven't been able to host a similar session to more explicitly discuss their contributions, but our hope is that these discussions can be facilitated and grow over time. So without further ado, I'd like to introduce the panelists who are joining us today. I will keep this short as they will each be able to share more about who they are and what they do during the discussion. And after our roundtable, we'll have lots of time for audience questions and discussion. So first we have with us Nicole Pasquino, who is an RN with certified practice in reproductive health. She is the faculty lead in sexual health at BCIT and the clinical director of operations for sexual health. Jane Narayan is a nurse practitioner and the clinic director at the Axis NP Primary Care Clinic in Surrey North Delta. And Jane is also the chair of the NP Leadership Committee at the Association of Nurses and Nurse Practitioners of BC. And finally, we have Angela Wignall, who is a registered nurse and the current Chief Executive Officer of the Association of Nurses and Nurse Practitioners of BC. We did have a 4th panelist, Penelope Smith, who is the Executive Director of the Glengarry NP-led clinic. However, Penelope is no longer with that clinic and so is unable to join us today. So with that, I'm hoping that we can jump in and get started. And to begin, I'd like to address this first question to Nicole and Jane specifically. So I'd like you both to each start by telling us a bit about your work context. So can you paint a picture of what your day-to-day practice looks like? So your practice model, your staffing, the patient population that you serve, your approach to service delivery, and your values. And then can you provide us with a few concrete examples of what that day-to-day might look like? So Nicole, if I could ask you to start.
Hi, thank you so much, Lindsay, and thanks for inviting me. I've been invited to talk about options for sexual health and its unique model of nurse led care here in British Columbia. So, I'm just going to start and talk a little bit about our organization. Options is a not for profit sexual health clinical provider here in BC. Currently, we operate over 30 clinics in British Columbia. 20 of these we operate directly, including a provincial telehealth program, which operates 4 nights a week. And several other of these we work in partnerships with other organizations across the province, and we're funded uniquely through health authorities and the Ministry of Health, as well as some other small portions of funding that we seek out on our own. Options roots began in the 60s as the Family Planning Association of BC, and many people are much more familiar with our previous name being the Planned Parenthood affiliate here in BC. So our commitment is really to providing access to confidential, non-judgmental sexual health care, and it's rooted really in reproductive choice, and that's been something that I think has held steadfast for the last 60 years. This organization has been around. Our mission is to champion and celebrate sexual health for all British Columbians. And in addition to our clinical program, which operates in these clinics I talked about, we offer in-depth school education program offered by certified sexual health educators. And we have a referral and information helpline called Sex Sense, which is operated by sexual health educators, nurses, and counselors. And we as an organization participate in advocacy across BC to improve sexual and reproductive health. Our clinics are located across the province, and they're often in spaces that are offered in kind, such as public health spaces or community-based buildings like the Community Health Hub or the Community Services Building in town. More than 80% of our sites operate in rural and remote locations, which is really important because it provides access to some of the populations in BC who really don't have access to specific sexual health care in their communities. Most of the clinics are open once a week in the evening, and some of them several times per week, and serve patients of all ages. Last year, we saw over 10,000 patients across these clinics. And we offer services like birth control counseling, free contraception, sexually transmitted infection screening, cervical screening, pregnancy testing, pro-choice pregnancy options counseling, and other general information and referrals. And often people are coming to see us because we speak the language of sex, and they know that they're coming and they can be in a comfortable place to do so. The vast majority of our clinics are nurse-led, so meaning that with the support of usually an administrative staff member, all options nurses are practicing to their full scope and running the clinic, typically on their own on that clinic night. And they all work within the certified practice designations. This means that RNCs, we refer to them as RNCs, can offer an advanced autonomous scope of practice within sexual health care. And it fits well within the primary care realm. It's defined by a scope, but it brings essential health care to communities where there's significant gaps to accessing specific sexual health care, maybe something like a IUD insertion or implant that they might not be able to offer somewhere else in their community. We are, of course, gratefully supported by some of our sites with MDs who work alongside our nurses in the equal care team model. So nurses seeing patients and physicians seeing patients at the same time. So my role as clinical director is really to oversee practice and policy and work alongside. I continue to work in our clinic here in Courtenay, BC, and I work with a really small but mighty team here in our what we call our main office, and it includes an operations manager, a clinical resource manager, nurse, a clinical resource nurse, and our medical director who also supports practice alongside me. Some concrete examples of some of the things that we've been able to do outside of, the realm of, say, a bigger healthcare system is during the COVID-19 pandemic, when patients really needed to see care for urgent things like abortion referrals or even getting a PAP because many people weren't seeing their regular point of care in person. We were overwhelmed with requests for these types of care. So continue to see things and do things like cervical screening and essential STI testing and referring people for abortions. Currently, Options is training 19 nurses across the province to insert IUDs. This is a new scope of practice that's been added and advocated very strongly by Options for nurses to be able to do. And so we're starting to see our first nurses come out, meaning that some of these communities that have absolutely no access to this kind of care, where patients may have to travel, are able to access things like long-acting reversible contraception, which we know is really impactful.
What a great start, Nicole. Thanks so much. Angela, I wonder if you might want to comment on what Nicole has said from a sort of policy perspective before we pass it over to Jane to describe the work that she does.
Absolutely. Good afternoon, everyone, and lovely to be here with all of you. And hands raised to you, Nicole, always for the incredible work and the leadership that you bring in BC. I think what always stands out to me when I listen to Nicole describing the work that she leads and that her teams do is how intentionally developed the model is in designing care around the need a person in community has, not around traditional role boundaries. So designing for people rather than designing for a profession. And of course, in this instance, with options for those who need it most and for those who are most vulnerable. At the Nurses and Nurse Practitioners of BC, or NMPBC, we've been really honored to work alongside Nicole and others in developing certified practice, and in particularly the recent advancement in adding IUD insertion to certified practice for RNs in particular. And I'll share that in British Columbia, we are extraordinarily unique in that we already have this blueprint for expanding nursing roles safely and effectively. And that is this idea of certified practice. No other jurisdiction in Canada enables certified practice as a practice category for nursing. BC is unique. We are leading, we are alone in this instance. And certified practice for registered nurses and registered psychiatric nurses encompasses four potential streams of work. So, what's called remote nursing, which is inclusive of a wide range of primary care activities, RN first call, which was initially designed to augment care in emergency departments but has changed since that time. Reproductive health, including sexually transmitted infections and contraceptive management, and the most recent certified practice introductions, which is for opioid use disorder, and that's also available to registered psychiatric nurses. These are spaces within which registered nurses and registered psychiatric nurses are practicing an expansive scope of practice, an autonomous scope of practice that includes the medical diagnosis of diseases, disorders, and conditions, prescribing for those diseases, disorders, and conditions, and a wide range of other activities that, again, I'm just going to emphasize are autonomous. It is what they can do independently as registered nurses or registered psychiatric nurses. And what's really important, I think, from a policy perspective around certified practice is that it's not just about that expanded scope. It's about the system catching up with what nurses are trained to do. This kind of work is who we are as nurses. It's the kind of work that we have been doing for centuries here in what is today known as Canada and for many, many years beyond that. And when we think about bringing certified practice into primary care more broadly, we know that we would bring in the improvements that certified practice brings along with it, which is improving access to care, as Nicole has already spoken about so beautifully, reducing pressure on existing professions within the primary care space, and really creating a more responsive, community-grounded, team-based care model for primary care. I'll add that adding certified practice nurses into these spaces is not exclusively about alleviating work from doctors, although that is a very good benefit. Certified practice nurses are autonomous. We don't require anyone to do the work that we do, and we're not a stopgap for someone else. Many places in the world use nurse-led models exclusively for primary care. And so in British Columbia, when we think about the opportunity that certified practice brings to us, it's an opportunity that is not theoretical. It has been proven for decades that it works. And now for us, it's about taking that next step into scaling certified practice intentionally into primary care.
Thanks so much for that, Angela. It's great to hear that. BC has largely been, I would argue, behind other provinces, particularly Ontario and Quebec, in terms of the formal integration of nurses and NPs into primary care practice. So it's really, really wonderful to hear how BC is leading in this certified practice space. Jane, can I turn it over to you and ask you to tell us a little bit more about who you are, what you do, your day to day?
Yeah, thank you, Lindsay. Thank you for having me this afternoon. My name's Jane Narayan. I am a nurse practitioner, and today I'll be speaking on behalf of Access Primary Care Clinic. I'm calling in today from the unceded territories of the Kwantlen, Katzie, and Semiahmoo Nations. I am the current clinical director for Access Primary Care Clinic, and we are a nurse practitioner primary care clinic in Surrey, British Columbia. So, Access Primary Care Clinic was established in direct response to a significant and growing gap in access to longitudinal primary care within our community, particularly for unattached patients who were navigating the system without consistent providers. The clinic originated through a formal proposal process in 2018 with the goal of designing a model that could improve both access and continuity of care while leveraging full scope of nurse practitioners within practice. We were successful at securing initial funding through a pilot, and this was along with with three other clinics, so Yates, Nexus, and Flowerstone on the island. And Access Primary Care Clinic first opened in September of 2020, and this was during COVID, which came along with its own challenges. We first started with 6 nurse practitioners, 3 registered nurses, and our MOA team. And from the onset, the intent was not simply to increase access, but to create a model of care that was sustainable, relationship based, and responsive to patient complexity. As the broader primary care landscape in British Columbia evolved, we became integrated into our local primary care network, or PCN. PCNs are regionally coordinated systems that bring together attachment and coordination at a population level. And so integration into our PCN allowed us to be more aligned with the regional planning, and it expanded our team and strengthened the interdisciplinary collaboration in a way that supports more comprehensive care delivery. And so since that time, from 2020 to 2016, Access Primary Care Clinic has grown both in size and in maturity as a model. Today, our clinic has 10 nurse practitioners for an 8.3 FTE, one a clinical director for a 0.4 FTE, 4 registered nurses for a 2.3 FTE, a clinical manager, and 8 MOAs. And these are varying FTEs. So this structure allows us to function as a true team-based primary care clinic with clear role delineation, but also flexibility to ensure that each team member is working to their full scope. Last year, we had 24,000 visits within our clinic. And we offer extended hours. So we're open from Monday to Thursday from 8 a.m. to 8 p.m., on Fridays from 8 to 4, and we do open on Saturdays from 8 to 2, allowing for increased access to care. From a leadership perspective, a significant focus in the clinic has been on building operational and clinical infrastructure required to support this. This is to ensure workflows, staffing models, and processes that are aligned with both quality of care delivery and also provider sustainability. So our model is strongly aligned with the principles of a patient medical home. And in this practice, this means that we prioritize longitudinal attachment, ensuring that patients have an ongoing relationship with the primary care provider who knows their history and who can provide continuity of care over time. We deliver comprehensive care across the lifespan. So we see patients who are newly pregnant. We then follow them through pregnancy and refer off after oftentimes 20 weeks. We do prenatal care, pediatric care, chronic disease management, and end of life. So we see everything. And we emphasize with the team-based care, where nurse practitioners, registered nurses, and our support staff all collaborate and provide coordinated, efficient, and patient-centered services. This is, in terms of access, a key pillar to our model, and particularly for patients who have historically experienced barriers to care or not being able to see their provider. The population we serve is composed originally of unattached patients, but as of recent, when individuals are retiring within our community, we've taken on those patients as well. And we see all primary care We see complexity in terms of chronic disease management, but also social complexity and mental health complexities. And in addition to direct patient care, we also place a strong emphasis on quality improvement and standardization. So, as clinical director, part of my role has been to ensure that are not only providing care, but we are always continuously evaluating and redefining how the care is delivered. And this includes implementing structures and approaches to screening, improving workflows, and ensuring consistency among providers within our clinic, but also to allow for flexibility and access. And so overall, Access Primary Care Clinic has evolved from a small NP-led pilot to a fully integrated team-based primary care clinic within our PCN. And it has demonstrated that nurse practitioner-led clinics can effectively increase access to care, deliver high quality care that's longitudinal, and that aligns with the broader system priorities, such as team-based care and patient medical home.
Amazing. Thanks so much, Jane. Angela, can I send it back your way? It would be great to hear you comment a little bit on what you heard from Jane and maybe bringing in some of the research evidence around the benefits of NP-led primary care clinics.
Absolutely. And again, it's always such a joy to listen to Jane speak about the work that she does and that your team does at Access or at Access. What I hear in Jane's description of her work is very similar to what I heard in Nicole's, is that these are not fringe models anymore. These are not potentials. These are real high-performing care models that are in place on the ground in British Columbia today. So when we talk about evidence for NP-led care, it is unequivocal. There is consistent evidence that NP and nurse-led care improves access, increases patient satisfaction, has increased and improved chronic disease management outcomes in particular, and is strongly cost effective. In British Columbia, we have seen a significant investment in nurse practitioners in particular, with the government of British Columbia doubling nurse practitioner training seats and increasing the workforce quite aggressively over the last few years. We've seen a full doubling of the nurse practitioner workforce in BC. And by today, that's about 1,500 nurse practitioners. And within the next 3 years, we anticipate that expanding to 3,700. So this is the fastest growing area of primary care provider in the province and indeed in the country. And according to the government of British Columbia's most recently released metrics, nurse practitioners are growing year on year at a rate of 137%. So again, this is very real. This is very on the ground today. And it is statistics and evidence that demonstrates the growing recognition of nurse practitioners as full service primary care providers. In addition, British Columbia and all other provinces and territories in Canada have been directed by the federal government to implement nurse practitioners as fully physician equivalent services under the Canada Health Act, which means that British Columbia must respond by including nurse practitioners fully in the publicly funded care sector. And I think what is often missed when we talk about nurse practitioners is why the nurse practitioner care is different, why these models work. And I think it comes back to a truth that I know as a nurse, and I know that Jane and Nicole know as well, which is that nursing is inherently holistic. It is inherently person-centered. It is prevention-oriented. And that translates into better long-term outcomes for patients, and in particular, for complex patients. What's interesting about the growth and investment in nurse practitioners is that this isn't just about adding more providers. It's about fundamentally changing the model of care itself. NPs are not physician stopgaps. We are not augmenters. We are fully autonomous care providers capable of independently providing care, as Jane demonstrates every day in the work that she leads. And I want to be clear that nurse practitioners and nurses do not practice medicine. We practice nursing. And as I said, nursing is a practice rooted in that patient-centered holistic care, but it's also rooted in the principles of equity, of justice, and in people-led care. And what that means is when people receive care from a nurse practitioner, they feel and they comment that it is different, it is unique. And evidence shows very clearly that this care is well received, that it improves outcomes, and that it dramatically improves population health as well as individual health. And I think something that sits with me every single day is the knowledge that when patients tell us about their nurse practitioner care, they say things like, "I've never felt this way before. This is different for me." Nurse practitioners provide that care in a highly cost-effective way, often in rural and remote contexts as sole providers or the only people there seeing or serving a community. But they also do this care as part of a team, as Jane does in established clinics and in NP-led clinics, where they lead teams of other providers, including other professions beyond nursing. I'm sure what you can hear from me is that it is hard to overstate the nurse practitioner advantage. And so when we think about addressing access, when we think about addressing systems sustainability around primary care, nurse-led models, including NP-led clinics, are not just a pilot anymore. They are essential, and we are working very hard at NMPBC to ensure that they become a pillar of the primary care system in BC.
Thanks, Angela. It's very clear that those comments really resonated with our participants. I saw tons of the little flying hearts and celebratory reactions. So clearly you struck a chord there. I'd like to go back to Jane and Nicole and actually build on quite a bit of what Angela was saying there, just around the future potential for nurse-led organizations in terms of the ways that they can improve access to high quality, cost-effective, team-based primary care. And specifically, I'm interested in whether there are specific populations or geographies that you both feel should be prioritized in this space. So maybe Jane, could I start with you there?
Absolutely. Yeah, so nurse-led primary care organizations they're significant, but yet, as Angela mentioned, largely underutilized, and has a huge potential within the BC healthcare system. And so over the last several years, we've seen meaningful progress with the shift towards team-based care, with the expansion of the primary care networks and the recognition of nurse practitioners as full scope primary care providers. However, despite these advancements, the system has not fully optimized or scaled NP-led primary care models in a way that reflects their demonstrated impact. And so the potential of nurse-led organization lies in the strong alignment with primary care, with patient medical home principles. So these models are inherently designed to provide longitudinal, relationship-based care that is comprehensive, coordinated, and team-based. And so they are very well positioned to address some of the most pressing challenges in primary care, including attachment, access, and growing burden of chronic disease and mental health conditions that we see every day. And so, because these clinics are not driven by volume-based incentives, they can focus on more intentionally on the community, on prevention, on patient-centered care, all of which contribute to improved outcomes and system efficiency. And so this model would be particularly well suited for rural and remote communities, but also in any community where there is a lack of primary care providers for British Columbians. And that is where access gaps are often most significant. So in these settings, nurse practitioners are able to function as full scope primary care providers, often serving the most consistent point of access. And so this would allow for that supported team-based culture.
Great, thanks. And Nicole, I'll pass it back to you, sort of same question, but also interested in your thoughts around the threatened closure last year, and despite the sort of potential for increases in funding going forward.
Yeah, thanks so much. And just like reflecting on Jane's comments, I think that the potential for nurse-led care, whether it be in primary care or in a model like options, is there. And often what we see is despite this continued need for care. So when we look at, I just checked our wait list this morning for IUD insertions, it's up to 8 weeks in some communities. Turnaways we have due to clinical capacity. And this increased scope of practice, which Angela talks about and we welcome, it does increase the responsibility and education demand on nurses. And so what happens is funding becomes a continuous challenge. So when we're speaking from our perspective at Options, until 2025, we had not received an increase in our core funding for over 12 years. So that resulted in huge barriers for our staff and ability to keep our clinics opening. Increasing costs of living for our staff, wages in nursing, and billing codes for MDs are much lower in reproductive health than they are in other areas. Because our clinicians work in a very specific area, they're not able to access programs like the longitudinal care program in BC. And so prior to 2025, Options RNs were working at approximately 25% less than their union colleagues, yet they were doing all the teaching of sexual health and providing autonomous care and being asked to achieve advanced certification, almost always working by themselves in clinical settings and being sole providers. And so it's been a challenge to keep the doors open, even though we know our services are really needed in these communities. So even though we have received a small increase to our base funding, it's a big catch up over 12 to 15 years when you haven't had any increase. So that resulted in us really looking hard at our model of payment for our staff and equity to ensure that our staff are valued. When I first started at Options and within the Planned Parenthood model, we often put onto nurses that we do this because we care so much. That doesn't mean nurses shouldn't be paid equitably to what they deserve. And so without a full increase and the ability to pay our nurses a fair wage, we had to make the decision to close some of our sites. And so effective March this year, Option closed 11 clinics. When I started Options, we operated over 50 clinics in the province, and now we're at about 30 to 35. And so we've had several closures over the year to meet the demand, not only in the communities where we need to be able to put the service, so making priority judgments around, is there other services available in this community? Is this a community that doesn't have any sexual health access? So, when talking about the closures, it's very difficult on staff and communities because very few clinics offer sexual health as an exclusive service. And we know with the advent of free contraception in BC, there's a huge demand for our services, and many programs, while they will fill gaps in other areas or while they'll fill those small gaps, the model of Options, and this is really where I'm leading into this question about future services of care, is part of the reason that the model works is because we see time and time again that patients really want to be coming to a provider that in sexual health care specifically is dedicated to sexual health. They provide a non-judgmental, confidential space, and they want to know that when they're coming here, that is what they can talk about. And it's not to take away from any of our colleagues or people who provide great primary care, but sometimes it's just not a comfortable area to talk to people about. That might be the auntie that you see at the pharmacy in your community, or it may be your friend's mom. So you want, the ability to be able to provide these types of intimate care. And some people do report to us that sometimes seeing their regular provider isn't accessible for them. We also see a lot of patients who actually don't have attachments or don't have access to family care providers or NPs. And so, accessing something urgently like STI treatment becomes such a burden on the healthcare system. So if someone has to go to emergency room to access that, STI care, which is an urgent need, but isn't necessarily something for an emergency, it starts to put, demands on the greater healthcare system where we can fill those spaces at a much more efficient and easier way. Our spaces are also open in the evenings, which makes a huge difference for patients who have daytime dedication. Really being able to be in the spaces where patients need us to be, as opposed to us being in a certain space. So those are things like high schools, pop-up clinics, other spaces. In communities, we're currently looking on the island about having a traveling clinic, because there's a lot of corridors in the island where, you know, people may have to travel up to an hour, 2 hours, 3 hours to be able to access care. So trying to look forward to how we can continue to offer these essential sexual health services, but in a model that ensures accessibility to patients in a cost-effective way, can shift the burden of cost and care to the wider system.
Great. Thanks so much, Nicole. Angela, before we shift gears to talk a little bit about some of the sort of policy priorities and future funding changes that might be needed, is there anything that you would like to reflect around future potential?
I think that, what stands out to me in listening, particularly to Nicole speak, is the reliance of our current system on goodwill. It is insufficient for a publicly funded healthcare system to presume that 60% of those providing labor in an area of work like primary care will simply volunteer their time to do so. Many of us do. Nurse practitioners volunteer their time in emergency rooms in rural settings. Sexual health nurses and certified practice nurses volunteer their time, like Nicole is describing. And we are caring folks. We are folks who are grounded in a profession that is dedicated to the service of other people. But we're also mothers, wives, fathers, husbands. We need the sustainment of our own lives to be able to be there to provide the care that we can provide. And so when I think about the systems challenges we're facing, one reflection I have on what Jane and Nicole have shared is that it is inappropriate for our publicly funded healthcare system to rely on the volunteerism of a 91% gendered profession.
Absolutely. Sticking with you, Angela, I wonder if we can talk now a little bit about what you see as the priority policy and funding changes that are needed in order for us as a system to optimize the potential for LPNs, RPNs, RNs, and NPs to be able to work in these collaborative team-based primary care settings, work to full scope, have the capacity and the tools that they need to provide high quality and prevention-oriented care in a way that they are effectively compensated for their work and not asked to volunteer, as you just pointed out.
Absolutely. So, as I begin to answer this question, I think I'll start with a very simple statement, and that is that I do not believe that we have a resource issue. I believe that we have a design problem. Nurses are already in primary care doing a huge amount of work. As I said, the last Carga report from the government of British Columbia indicated that over 60% of engagement care and provision of care is being done by nurses and nurse practitioners. So that is an enormous amount of what we describe as primary care today. And the question is not whether or not those people are providing care. It is whether the system is enabling that provision of care effectively. So one thing that we have been very vocal about is that we need to move beyond the fragmented program or individual clinic owner system and invest in a coordinated province-wide learning health system. And what we see in countries who've taken this approach around primary care is that when they enable a system that includes quality improvement infrastructure, as Jane so eloquently spoke to, clinical practice supports, data and evaluation, which is a critical component of demonstrating that we are, in fact, doing the thing that we say we are doing, which is achieving individual and population health outcome improvements, and the establishment of shared standards. We see those investments result in better health for people, which is really the goal. The goal is about ensuring British Columbians live, thrive, and die when and how they feel supported in doing so, right? As Nicole said, they see folks in reproductive health. As Jane says, birth to death is the full spectrum of what we are talking about here. So at NMPBC, we have been very fortunate and have worked very hard to provide a provincial example around the Nurse in Practice program. As I believe was mentioned, Lindsay, in your opening remarks, the government of British Columbia opened a new funding model called the Nurse in Practice model, which enables physician-owned or NP-owned clinics, as well as nonprofit agencies, to hire an RN or an LPN into a primary care setting. That is a publicly funded contract, so that nurse is a publicly funded role, but they operate within the staff complement of that team as opposed to through a health authority contract. When that was opened, we were very clear in saying, fantastic, you funded a job. Excellent. We need that job. Nurses need to be in that space. But there is an invisible infrastructure that sits underneath that nurse that also needs to be present. And so, in partnership with the Ministry of Health, we created the Nursing Initiatives for Primary Care, which is a program that supports community for nurses who are engaged in primary care provision so they can speak to each other, share best practices, have camaraderie and community, often when they are alone in these spaces, but also an on-the-ground, shoulder-to-shoulder practice excellence team that provides these nurses with structured supports, with tools, really enabling that full learning health system. And what we see as the outcomes of the nursing initiatives for primary care is that these nurses thrive, but really importantly, the clinic and the team around them also thrives because they understand the role of the nurse. They understand how and where to move patients toward the nurse independently and where other practitioners might be needed. And that enables those nurses to work to full scope, to work expansively in a way that really maximizes access and care. This, of course, then benefits nurses, it benefits teams, but really importantly, as I said, it benefits patients through consistent, higher quality care. So when we talk about adding nursing into primary care or enabling it, we're not just talking about opening up a job, we're talking about that full learning system in primary care. Another piece that's really missing in our policy environment is standardization or an articulation of what the strategy for primary care is in British Columbia. What is the model for primary care? Right now, we don't have those system-wide expectations or articulations that say, this is what good primary care looks like. That is a provincial standard, that is aligned performance indicators, and there is ample evidence from around the world that when we talk about setting standards, we can code it around wait times, we can code it around continuity, we can code it around patient experience. But what we know doesn't work is simply measuring it in terms of attachment, which has been the primary indicator here in British Columbia for what good looks like in primary care. Without those standards, we get intense variability. And with standards, with a learning health system approach, we get that systems level improvement. We start to establish expectations. And really importantly, we can start to see where we're missing the mark and how we can do better. Right now, we're operating a lot in the dark in terms of data. As I mentioned before, nurses and nurse practitioners are providing the vast majority of primary care in the province. And we need opportunities to deepen the evaluation of that work, to bring forward in evaluation nurse-sensitive health outcome indicators, of which there are many, and to expand nursing roles, not just in attached primary care, but also in episodic care, in areas of specialty practice or focus practice, like Nicole is describing at Options. And so a critical ask from NMPBC to the government and the Ministry of Health in the primary care reviews that are underway is, where are the nursing researchers? Where are those nurse-sensitive health outcomes in the evaluation framework? And how is the labor and contribution of nursing knowledge and nursing practice translating into the findings that will lead to policy change? And then the last thing that I'll add here is that we need to change access to nursing roles, and that is fundamentally a shift in funding. We need to fix the models that enable team-based nonprofit care in particular. And we're at a really pivotal moment when we think about nurse practitioners in particular being directed by the federal government to acknowledge them as physician equivalent providers. But today, on the ground in BC, that federal direction cannot be realized because the two employment models, the two compensation models that enable NPs are not flexible enough, expansive enough, or responsive enough to rise to that challenge. Without those right provincial funding models, we risk defaulting into small or fragmented pilot projects, which people always like to joke, BC is the land of pilots. They're not always wrong. And instead of team-based community-driven care, we get these one-off opportunities that are demonstrating the value, but that infrastructure for funding, that backbone for nurse practitioners to hang a shingle and say, I'm here, I'm ready to provide care, I can lead a team, that is simply not available right now. So if we imagine a vision, particularly for nurse practitioners, but really expansively for any nurse who wants to provide primary care, we can scale clinics, we can build community-based models, and we can create that equitable access across British Columbia. But it requires an expansive, courageous policy shift, a redesign of a system that actually uses the resources we have on the ground today.
Amazing. That was so fantastic, Angela. Thank you so much. And before I pass it back to Veronique, because I noticed we've got a ton of great questions in our Q&A and our chat, I just want to draw your attention to this great comment in the chat by Sybil, who says, I think it would be valuable for you to present this content on global news so the public hears this perspective and can advocate for it locally with politicians and health system leaders. So with that, I will pass it back to Veronique to manage our Q&A.
Yeah, thank you. As Lindsay mentioned, there's a ton happening in the chat here. And so maybe I'll pick up on one of the last things that you were talking about, Angela, with the federal directive around, the equivalence between accessing a nurse practitioner or accessing a family physician. From the patient side, we've got one question around, there's a bit of confusion for the patient side of, what is the difference between accessing a nurse practitioner or a doctor? We've got some questions around, how do these terms are different between provinces? So, in Saskatchewan, it might be advanced authorized practice versus here it's certified practice. And so I think, could some of you speak to what does it mean for a patient when you go into primary care? I mean, we've been talking about access being the most important thing. So maybe we can talk about the distinctions between a family physician or a nurse practitioner or the certified roles in terms of what does a patient get to access? And I'll leave that open to whoever wants to jump in and answer that question, either from the practice perspective or the policy perspective.
I can start from a practice perspective for nurse practitioners from that lens. So oftentimes we're met with this exact question when we're intaking a patient, right? So in BC, oftentimes individuals will come off the Health Connect registry, which is a portal for unattached patients. And they get assigned to either a nurse practitioner or a family practitioner. And that is the question that they ask, what is that difference? And so in BC, we're autonomous providers. We're able to diagnose, prescribe medications, refer on to specialists. The only thing that a nurse practitioner in primary care in British Columbia is unable to do is deliver babies. So we see everything from the time that you're pregnant up until about 24 weeks. We then refer on to an OB or a midwife. And then after baby is born, we see you after. So we don't do that intrapartum care. Other than that, we do everything. And then we oftentimes talk about the schooling. So at the end of the day, a nurse practitioner, we typically went to nursing school. We were a registered nurse. We went back, did a master's level program, did our examinations, and then went on to be certified to be a nurse practitioner in comparison to a family provider who went to medical school, then went on to do the residency of family practice. And so essentially within the primary care space in British Columbia, the intrapartum care is the only restriction for nurse practitioners currently. Other than that, our scope does align. And that's a very great question and a question that we get often. So I can hand it over to whoever else would like to speak about the differences there.
I know there's a lot of questions around the difference between certified practice, which I'll be happy to speak to a little bit of it, but I'm sure Angela could add. And so, certified practice is very specific in its scope, so different than NPs where they have a general and wide scope like a family provider. We work in partnership with our colleagues who are NPs or MDs to look at something that's very focused. So in my area, that could be contraception or STI care or general sexual health, guided by guidelines that are actually housed and supported by NNPBC. And it is surprising for patients often to hear that we can diagnose, order our own tests, do our own procedures. We are autonomous. And now we can also prescribe. So there is a really, while it's a wide scope, it's a very specific area. And so those categories that Angela talked about earlier all have their place. So again, it's, Angela speaks so eloquently that we're not here to replace anyone. We're not here to take anyone's job, but we're providing a really safe space in sexual health for people who may, often it is the most vulnerable people who may not have a place of safety that they can go to, or they really want to talk about, anal sex. They're not going to talk about that with their family provider who delivered them at birth and they see with their parents, So these are things that, people come into us because they have a certain level of comfort, and they will really come to us knowing that we have a level of comfort in sexual health, and we can talk to them about that. Everything goes. I tell patients all the time, we get a lot of apologies from patients. I'm sorry. And I just say, people tell me everything. I'm open to anything. And I think that's part of why our lens within sexual and reproductive health really works, is it's quite an intimate area. And so it's a really vulnerable place, not just for populations who are vulnerable, but for any of us. How many people here sitting on this phone conversation are willing and open to have a sexual conversation in their workplace or an open setting? Not very many. So that does also work for other areas that are certified practices Angela discussed. And I think that one of the things that, the future holds is that there are the concept of expanding certified practice within nursing to allow for these kind of areas where nurses are already doing the work. So before certified practice existed, options existed for 50 years. Nurses were already doing this work. It just gives us the ability to have more control on our day-to-day practice, and to be able to not have to jump through hoops to say, do something like provide someone with Plan B or contraception or put their IUD in. Nurses have been doing pelvic exams in a trauma-informed way for, millennia. And the skill of doing an IUD is just a simple change in legislation in order for nurses to be able to train and do those kinds of works that they're already really doing. So I think, I'm really proud of BC that we're on the forefront, but I do think that there, as Angela mentions, the way the system is designed doesn't really support the compensation and work that's being done.
Yeah, I don't know if you wanted to jump in there, Angela, but I'll add there is a question in here around compensation for nurses, for nurse practitioners. Could you maybe, I know you did all talk about this a little bit and the way that affects, the funding you can access. I'll ask more questions about funding later, but can you go into a bit more detail about how nurses and nurse practitioners are compensated and how that might be different than how physicians are compensated?
I think it's a standoff between Jane and I on this one, isn't it? Do you want to go first, Jane, or shall I? Okay.
You can go.
All right, sounds good. So first off, I'll say that there are a wide range of employment models for nurses and for nurse practitioners when we think about the full nursing family. So that's LPNs, RPNs, RNs, and NPs. If we focus in on nurse practitioners currently have two funding models in the publicly funded healthcare system. One is through a primary care network contract, and the other is through a health authority employment contract. Both functionally land the NP as a primary care provider in community, but how they are funded, how they operate are quite different. They generally require the nurse practitioner to attach a certain number of patients. And because they are fairly inflexible, they don't allow a nurse practitioner to do some of the things that you might expect a nurse practitioner could be able to do. For example, if that nurse practitioner is providing coverage in an emergency room, that nurse practitioner is not paid for that. They just simply do that. If a nurse practitioner is working over and above 8.5 hours a day, they are simply working for free during that time, because there's no additional aspects of the contract that would allow them to expand their hours or whatnot. So we see these models of compensation that have been enabled and have brought the NP contribution forward, but they don't they're not designed for nurse practitioners to really reflect the work that they do. For registered nurses, registered psychiatric nurses, and licensed practical nurses, it is a huge range. So you might have a nurse who is employed by a health authority who works in an urgent primary care center, a UPCC. You might have a nurse who's employed by a physician who owns a clinic, and they've decided that a nurse in their team would be really helpful. And so they pay for that nurse's salary out of their own clinic earnings. You might have a nurse in practice that's funded by a contract with the government of the British Columbia that pays the clinic to have that LPN in practice, and therefore that clinic is reimbursed, as it were, for that publicly funded position. Because, as I described, there is so much heterogeneity, there's so much diversity within this, it's actually quite difficult to name all of the different ways. But what I can say is that there are some really consistent gaps. So one is that there are very consistent gaps in communities organizing for themselves and hiring nurses. There's not a lot of direct mechanism, for example, a nonprofit community-driven healthcare center to go out there and say, we really want a nurse here. We're going to ask the government for that. There's not a mechanism. There are community health centers that do receive funding for nursing staff through a wide range, again, of contracts that are available to community health centers, but they're really varied, and it depends on how the community has organized. So I know that this answer is unsatisfactory, and I hope what you hear from me is that because there is a lack of strategy for nursing in primary care, it's actually difficult to help people navigate towards hiring the nurse they need.
Thank you so much, Angela. Well, this is kind of also a question for you, so sorry to keep putting you on the spot, but can you speak a little bit more about the scope of certified remote/rural independent practice and its potential applicability to primary care in larger communities and team-based care, that are co-located with nurse practitioners and family physicians?
Absolutely. But I saw Nicole put her hand up and be like, I want to say something. So
Oh,
I don't
yeah.
want to.
Go ahead, Nicole.
No, it's okay. I just wanted to mention, to add on to what Angela is saying around the varied way that nurses are paid, because I think it's a really important point, is that if you don't work within a setting that is unionized in British Columbia, your pay can be very inequitable to those of your colleagues, even if you're working in an advanced practice or like an enhanced practice way, like certified practice. So despite nurses with certified practice being able to diagnose, now prescribe, now insert IUDs, now able to run their own tests, order their own medications, there is no compensation for that. That is just a add-on for free, right? So we do pay for education. So, and I missed this in my last mention, but there is intensive education. Nurses are required to do 12 weeks plus a practicum for STI, and then another 8 weeks for CM. And it's similar education for the other certified practice areas. And usually it's at their own cost if they're not working within a health authority or sponsored, but there is no additional compensation to their practice, increase of responsibility with no compensation recognition.
Thanks for adding that, Nicole. Yeah, thank you.
So, Veronique, to the question around certified practice, I'd be very happy to drop in the chat the link to the BC College of Nurses and Midwives Learning Center on certified practice, which articulates the 4 different certified practices, the limits of their scope, and the full breadth of what they can do. But I'll just restate that there are 4. One is called remote certified practice, and remote is the closest that we currently have to a primary care certification. It wasn't designed to be a certified practice for primary care. It was designed back in 2005 to enable nurses primarily in rural settings or remote settings who are the only provider. So they're the only person, for example, in outpost nursing. They're the only provider in a northern community. And they are actively engaged in advanced practice. Again, to Nicole's point, this was already happening. Nurses have been doing this for decades, if not centuries. And this was a way of wrapping public protection around that, really from the regulatory body's perspective. And so remote certified practice nursing articulates a range of diseases, disorders, and conditions that the certified practice nurse in a remote, with remote certification can autonomously diagnose, prescribe for, treat, follow, and of course, always, if necessary, escalate care to the next provider that's required. So, of course, we always work in a care ecosystem. We're not completely alone. There may be a time when one of our patients does not fall within the scope of our practice, so we would need to move that patient or refer that patient to the right level of care. There's also RN First Call, which some people jokingly call remote light, because it is similar to remote certified practice, but just a smaller number of diseases, disorders, and conditions that RN can autonomously manage. There is reproductive health, which has two branches: sexually transmitted infections and contraceptive management. And then there is now the new certified practice for opioid use disorder, which is open to both registered nurses and registered psychiatric nurses. In all, these nurses have prescribing authority once they've completed prescribing education. Every single one of these certified practices require additional education, codified programs that they must take, graduate from, and demonstrate competency in. In these certified practice RNs and RPNs use decision support tools that are housed here at NMPBC as well as at BCCDC and BCCSU, depending on which certified practice you're in. And those decision support tools guide the certified practice nurse's practice and support with high quality evidence. And I can tell you, as home to those decision support tools for many of the certified practices, we take a very strong high quality stance in developing these clinical guidance tools, which includes full policy lifecycle management, integration of evidence. We have multidisciplinary teams that review these decision support tools to ensure that when we give clinical guidance to certified practice nurses, it is of the highest quality. It is the most current medical evidence and research evidence that they can have to guide their practice. And really importantly, as always, as I've said, these certified practice nurses work in an ecosystem. So certified practice also articulates when that certified practice nurse would need to hand off or escalate care to another provider, like a nurse practitioner, for example. In an ideal world, you could have a primary care clinic that was entirely comprised of nurses, where NPs, certified practice RNs and RPNs, RNs, RPNs, and LPNs are all working together to the full scope of their ability in providing care. And I think what's often interesting when we talk about primary care is people presume they need an NP, or they presume they need a certified practice RN or RPN. And I think what is very poorly understood is the true breadth of normal, I put myself in that bucket, I'm an RN, RN, RPN, and LPN practice. Nursing as a family can do so much. And unfortunately, the system doesn't always enable us to do that.
Thank you, Angela. My next question, I think, any of you could answer. And so I'm including you here, Lindsay, because I know you've thought a lot about how primary care is funded. So the question, and this is a big question, so take whatever piece of it you'd like to, but, what are the ideal funding? I've got a few parts of this question. So I guess what are the ideal funding models, that would help facilitate? And I think not only nurse and nurse practitioner led clinics, but maybe the broader team-based care model that you're all really talking about here. And is that are we looking strictly at government funding model, or is there a way that clinics can seek funding from other sources, and what would enable them to do that?
Well, if I could be so bold, I think the most important thing that anyone who is looking for change in primary can do is get political. These systems are not going to change without us standing up as citizens and as professionals and saying that things must change. At the end of the day, team-based care fails when funding models are individual provider focused, and equity improves when care is designed around populations, not billing structures. So when we say we need flexible, comprehensive strategies for nurse practitioners, that's exactly what we mean. And we need people to stand with us and say, that's what we want, that we want nurse practitioners, we want nurses in our communities, we want the government of British Columbia to enable the workforce that they have. So if I could be so bold, that is first and foremost. Structures need to change, and we need to demand that change.
take a risk and jump in after Angela's absolutely spot on comment and just say, in some ways, I would push back on the framing around the issues related to the how of the payment model. That I think so much of the structural change that needs to happen to enable true interdisciplinary team-based care that is directly responsive to community needs fall outside the boundaries of how we are paying people. If we can sort of take a slight aside for a second and look at our history as a province of how much tinkering we've done with respect to how we pay physicians, and yet we are still facing these challenges going forward. So all of this playing around with the mechanisms for funding doctors hasn't addressed a lot of these challenges. And so I would say that for me anyway, the biggest structural pieces are focused more around the infrastructure side, not so much on the how we are paying our wonderful staff side of things, right? Like there's been some great work in small communities where municipalities have literally bought up physical spaces and invited folks to come and work there, where they're not responsible for managing the day-to-day of that clinic. Like they are there to provide their quality care to full scope, and those administrative tasks are sort of not the responsibility of the care team. So for me, it's a broader move away from this structure of either independently or privately owned physical spaces, and as a community investing in the public spaces where people can come and work in a way that is directly responsive to community. So
Can I just add to that? I'll be so bold to go after these very eloquent speakers. Is that one of the ways that Options has been able to succeed in continuing to offer service in community is by doing that in a way that we access space often in kind. But this isn't an easy task. And so I really take your point around these community places where people come, because I think that many needs can be serviced under one roof, yet we are constantly stuck in a loop of competition. And so even when we move into a space where we may be invited, we are seen as competitive, even though we're doing something different. And, I will say that we are very reliant and we are very grateful for our health authority partners in areas where they have offered us space, because they know that we can provide the type of care that they may not be able to service at that time. And those partnerships, when they work beautifully. And I have always felt, I've been in this position for almost 2 decades now. I've always felt that I do not need to be the person that services the community. We just need a collaborative group of people who can service the community. And when we're talking about these team partnerships, saying community spaces, instead of phrasing it in my clinic will do this or my clinic will do that, it's how about the patients in our community need this, and we as responsive care providers are going to serve this population together. It's really about the population, and it's not about the model that we want to have. So I think the more we can move away from that, we will be more responsive and accessible to the communities.
And I'll just add into what Nicole has shared so eloquently, that we know that our colleagues in other professions feel the same. When we speak with colleagues who are social workers or clinical counselors, registered dietitians, doctors, they are asking for the same thing. When I speak with new graduating physicians, they are saying, where is that team? Where are the people that I can work with? So these challenges are not nursing specific. They are absolutely structural challenges that impact every profession who's working in this space. And when we get it right for nursing, just as we say in some of our other work around equity and anti-racism, when we get it right for nursing, because we are the largest group of care providers in the province, in the country, and on the planet, we have a really good chance of getting it right for everyone else too.
Thank you so much to all of you. I think that was a very difficult question and you answered it very eloquently. But I like that there's not, we've got a comment in the chat about that this sounds like the community health center model, but I like that you're pointing towards, there's not one universal model that has to fit every community, but when you go based on community needs first, multiple different models, team-based flexibility will pop up to service what the community is asking for and needs, and that might change over time. So keeping that flexibility is really important. I think I've got time for this. There's like a last little group of questions here around, we've been talking about accessibility. We've been talking about spaces, I think, in a very physical sense, but we've got questions around what kind of virtual services you folks offer. So both at Access, at Options, is there virtual access to nurses and nurse practitioners? Is there virtual classes for sex education? Do you engage in, and maybe Angela, you could answer this part of the question, are there any like peer-to-peer supports that are available virtually? So in what ways do you folks incorporate virtual tools into your practices?
I can go first just around the care and education aspect. So Options does run a provincial telehealth program, which was in response to the COVID-19 epidemic. We talked about it forever, and then in 3 weeks we had it. And it is MD led. We have a wonderful few MDs who lead it. And particularly, we are really hoping to add nursing to that. However, due to the funding model and the fee-for-service billing, we do not have the funding to add to that, but you can reach a telehealth doctor. I think I popped the link into the chat and make an appointment. And, they work with all of us at Options and are a wonderful person, a couple people. So yeah, it's very busy. I believe last year they saw over 2,000 patients in the evening only telehealth service. So we offer that. And then as in reference to the sexual health classes education, I'm going to make an assumption that this means like in school education, but this may be other avenues. So Options education team, wonderfully led by Kristen Gilbert. Anyone who knows her will love her, but she will offer basically personalized classes for groups that are looking for them. So they do a lot of in-person in-school education from K to 12. They're in schools every single day. Obviously, during the pandemic, there was a lot of that was virtual presentations, and they will adapt based on kind of the needs of who they're working with. Our education team also does a lot of professional educations for groups like BCTF and other groups who are looking to improve their skills. We also offer sexual health educator certification, which some of that is also online. So it just depends what you're looking for, but our education team, you can just reach out to them and they're happy to tailor their programs towards what is needed for your group or your school.
I can go next. Yeah, so I think in terms of the COVID-19 pandemic, it has absolutely shifted healthcare. And so particularly in the primary care space, 50% of our visits are virtual. So that includes anything from refilling a prescription, following up on labs. So for our clinic, over 12,000 visits were done virtually just last year. So it is a significant number. Obviously, when the individual needs to come in for abdominal pain or fracture or something like that, then absolutely that in person is offered. But I think primary care, just as a general consensus and over many different clinics, there is a component of virtual care that still continues, and in addition to the in-clinic care. In terms of our clinic and in terms of nurse practitioners that are on PCN contracts or within primary care, even within the health authorities as well, there are a few peer-to-peer supports. So individuals may access the race line, so that's to specialist consultation. And then within the primary care space for nurse practitioners, we also have mobile skills. And so if there is individuals that require consolidation of skills or they require cardiology or suturing or something like that, then that is a peer-to-peer session that they're able to book. So there are those supports available for NPs.
That's great. Thank you so much to both of you for answering those questions. I'm going to wrap up the questions there out of fear that we run over time, but also because I wanted to save the last few minutes to give each of the panelists and Lindsay, of course, feel free to jump in here, just a minute or two each to leave us with a final thought. You know, what the final thought is that you'd like to leave the audience with, or I sometimes ask, like, what keeps you going despite all the barriers to, good primary care. I see you continue to work every day on this. So we can start with maybe Nicole, then Jane and Angela and Lindsay. If you'd like to add your thoughts, I'll go in that order.
Thanks so much. And thanks again for putting this together. It's been a wonderful panel. I think for me, I'll speak specifically to sexual health and options in the work that we do, and understanding and framing that sexual health is a fundamental human right within healthcare. And, with ever changing priorities and landscapes in healthcare, we often see sexual health push to the bottom of those priorities. And so really wanting to ensure that from our lens, this right is protected, and that all people in British Columbia and all of our patients can live their best sexual health lives, but they can't do that without access to confidential and non-judgmental care. And not just when they're teenagers. This is across their lifespan, and it is a part of every single person. And I think that we have demonstrated and talked a lot today about this, but nursing at all levels can contribute to this and can foster and ensure that this continues throughout people's lifespans, in order to, not just focus on, say, like an STI or a contraceptive need in the moment, but living our best sexual health lives as we go into even, adulthood and seniors. So for us, I think that would be a big priority around keeping that at the forefront of healthcare.
All right, I can go next. So what keeps me going in this work is seeing that tangible impact and the continuity and access to primary care it has on patients and their lives. And so many of the patients that we serve at Access previously didn't have a consistent provider, and they were navigating the healthcare system in a very fragmented way. So going to Emerge, going to urgent care, going online. And so being able to offer them longitudinal care that's with a known provider, that's supportive, that follows them over time is really meaningful. And oftentimes I see patients who are pregnant, and then I see their first child, and then I see their second child, and I see their parents. And so that experience, that longitudinal care, I find is what keeps me going. And then from a broader perspective, what is also equally motivating is being a part of building and redefining a model of care that has the potential to be scaled across the system. So we know that NP-led clinics, primarily in the primary care space, it's not just an alternative model, but it is highly effective. And it does align with a lot of the healthcare needs and the increasing demands, the accessibility, the complexity, the resource constraints. And so it's a real opportunity to improve access to care for patients, to reduce those inequities, and also to develop a sustainable model of care at the systems level. So I think those are the things that keep me going.
Oh, I love those reflections. What keeps me going every day is a fundamental belief that change is possible. These structures and systems that create the world around us, they are choices that we have made. And we can choose other things. We can choose better things in some instances. And as somebody who has benefited personally from the care of nurse practitioners and who have trusted my children to the care of nurse practitioners, I see every day the value and the true quality of care that my family receives from an NP and a nurse-led team. And I also, as a nurse myself, know that our purpose, our calling, if you want to call it that, is to support and improve other human beings' existence on the planet. And there is no higher calling for me than that. It is endlessly life-giving, not life-taking. And so it is easy for me to keep going. And what I would say in closing is that we have the evidence, we have the workforce, we have models that are already working. And to Lindsay's excellent point, the question I think today is not do we continue to incrementally adjust the system that we have or tinker with the status quo? The question is, do we have the courage to intentionally design the system that we actually need? And I believe firmly, I know that nurses are leaders in that redesign, not just providers, not just implementers of someone else's good idea, but the designers of better care.
And I guess for me, the thing that keeps me going is seeing evidence everywhere of the true value of strong and community responsive primary care. And therefore, the real need for us to keep pushing for that structural change that will allow us to get there, allow us to build and support those teams who are there to be responsive to the needs of their communities. Beyond that structural change, I think there are changes that have to happen at the training level. And Ali, I'm sorry we weren't able to directly respond to your question in the Q&A there, but I think you're absolutely correct that there are challenges that are happening very, very early on at the training stage. And it's not just in the context of nurses training, but also physicians and other health professionals, that if we're training these folks in complete isolation, they graduate from their programs without the understanding of how to work together and how to maximize the overlapping scopes of practice that they share. And so, yes, we need to be training our professionals alongside each other so that right from the start of practice, they're ready to move into these models where everyone is working together to full scope. I'll just close by saying we have some amazing work that's being done here in BC, and we need to learn how to leverage this. It's been a privilege to listen today to some of the great work that's been going on. There's also great evidence from other jurisdictions that we can look to in terms of models of primary care that really are best positioned to keep those community needs at the forefront. And as a scientist, pushing forward to continue to refine and improve that evidence to support the needed best practice change. That's what keeps me going at the end of the day.
Thank you so much to all of you. Thank you, Lindsay, for facilitating this conversation, Angela, Nicole, and Jane for telling us all about the work that you do. This has been the fourth session in our five-part series. So if you'd like to come join us for the last part, that will be April 22nd. You can register on our website. We're going to learn from Oregon, who is quite further along in their primary care system transformation. And so we can see, what's left for BC to do. Not just, we've learned a lot from what's working on the ground in BC, but it is also helpful to see, what were those levers, those mechanisms that helped an entire state really completely transform their system and save a lot of money. So we'll be learning from folks in Oregon in a couple weeks. I highly recommend you register for that session. And then all of this work is going to live on our website on bcpolicy.ca/primary-care. And you can see these videos, you can read about these different programs. We'll have a discussion paper that kind of ties together all of the work that you've heard folks talk about throughout this series. And you can use that hopefully in your own advocacy, in your community, towards the Ministry of Health, the government, to push for change and, support everyone that you've heard here today in getting that system transformation we're looking for. So highly encourage you to sign up for our newsletter, and you can get all of that stuff right in your inbox. So thank you again, everyone, for joining us past your lunch hour, on this very sunny day. I think this is really important work, though, and it was hopefully well worth your time. Thanks again, everyone, for joining us today, and thank you to the panelists and Lindsay.
Thanks for leading us, Veronique. Thanks for leading us.